Texas Lutheran University.
Welcome to a biology-chemistry joint seminar. Today we welcome Dr. Jo Muse. She's the Chief Medical Officer for the state of Texas.
That's
right?
my current title.
Okay, so be nice to her or you'll never get in the hospital. She has a lot to tell you. I'm not going to tell you too much about her background because she told me that she's going to take care of that.
Yeah.
Pay attention, listen up, and have a good time. And let's welcome Dr. Jo Muse.
Thank you. So is my mic on? You can hear me? And I see that there's that camera up there trained on me. This is like maybe only the second time anyone has bothered to tape me for posterity. And I have to start with the story about the last time this occurred, which was 1992. I was pregnant and I was giving a talk on how to do case formulations to state hospital staff and various other people. And so here I'm very pregnant. I'm like 7 or 8 months pregnant. And I'm talking, and I have a co-presenter. And he was kind of an interesting fellow. And during the presentation, while I'm being filmed, some flying insect lands in my hair. We're in a completely enclosed studio, you know, no windows, like where did this insect come from? So this insect lands in my hair. I just keep talking. I'm not going to pay much attention to that. But my co-presenter felt that he needed to do something. So he takes a big thing of paper and whops me on the head in the middle of the presentation while I'm being filmed. And I turn to the camera person. I go, "You are editing that out, correct?" And I heard later, I never saw the tape. I heard later, they never edited it out. So I am going to check up on you. If anything untoward happens, your job, or somebody's job, is to edit it out.
If you want, I can hit you in the head.
Oh, no thanks, no thanks. I'm sitting down mostly because I have chronic fatigue, and if I stand, I'll get too tired and, you know, try to take a nap behind the thing there. So my name is Nina Muse. I am the Chief Medical Officer for the state hospital system. That means I am responsible for 10 state facilities. We have 9 hospitals and 1 residential treatment center for adolescents. It's a paperwork job. I mean, I'm in administration. I don't see patients anymore. And I've been in a version of that job for about 18 years or so. The first thing I want to let you guys know is this is not a presentation so much as it is a conversation. So you can interrupt me, you can ask me questions, you can make comments. Try to be nice. But I do better as a presenter if I feel like I know what people in the audience want from me. So I'm going to sort of launch into some stuff. But if any of it interests you and you want to go further that direction, you should just ask me a question and I'll head off in that direction for a while. I am from Texas. I'm from Austin. I grew up in Austin. I am first-generation college educated, which means neither of my parents were doctors. I didn't know anything about any of that. And they hadn't been to college either. I was the youngest kid in a family of 3, and there was no expectation that I'd do anything of this sort. It was sort of like grow up, get married, have kids. That's what my parents had done, and my father worked, but he was retired and disabled by the time I was in high school. It turned out I had an aptitude for school. I was one of those sort of quiet types, and all the way through. And I did very, very well in school, and I found it very, very easy. And I guess it was in my junior year, somebody mentioned, "Oh, so you're the brain, are you going to Harvard?" And that had never occurred to me about things like that. And I went, "Oh, maybe I could do that." So I applied to Harvard, Yale, and UT, and I got into all 3, and I went to Yale from a very non-academic high school in Austin, Texas. It was quite the culture shock. 90% of my Yale class, and you'll now know exactly how old I am, in 1972 declared themselves pre-med. Very competitive, very cutthroat. Everybody wanted to get into med school. It was very competitive then. I don't really have a good feel for how competitive it is now, but it was very much then, and it was like overwhelming to be around everybody wanting the best grade possible, and they're all these very smart Yale students. So I did okay. I was nowhere near the best student or anything, and I'm here to tell you that you can drop out of chemistry and still get into medical school, because that happened to me. I was flunking freshman chemistry and dropped it. And I tried again one other time, and then finally I took summer school. I went to summer school at UT Austin, and that's where I took the courses that I couldn't pass at Yale. I took organic chemistry at UT Austin, and I took introduction to physical chemistry at Austin. And I did very well there. In that particular environment, I was home, and I was a little more comfortable. But I still didn't decide I wanted to be a doctor. In fact, at age 7, if you had asked me what I wanted to do, I would have said, I want to be an archaeologist. And what was interesting is I also would always follow that up with, but I don't want to be a doctor. Now, why would that have even arisen? I didn't know any doctors. Nobody had asked me about that. But I was really clear I didn't want to be a doctor. So you have to understand I had a certain amount of resistance to doing that. And it's when I went to college, and all those other students, they all wanted to be doctors. And it was overwhelming. And I was very homesick. The whole time I was on the East Coast coming from Austin, I was very, very homesick and longed for home. And I finally did come home. And this was the mid-'70s, and there were no jobs. The economics were really bad. The economy was very bad in the mid-'70s. And here I was, a Yale graduate, and I couldn't get a job. Literally, I would apply. And I know you think I look wonderfully young now, but at 21 or 22, I looked like I was about 12, and I probably acted kind of like I was 12. So no one would hire me, and I was very, very distraught by that. I come from a family whereas you hit that age, you were on your own. I didn't dare ask my family for any money. So in desperation, I decided to volunteer at the Austin State Hospital so I wouldn't be home all day, because I figured that would be really bad for me. So I volunteered as a child care worker on the children's unit at Austin State Hospital. And I would go there 4 hours a day. I did it for months and months. And finally, a job opened up to be a child care worker. And I thought, a job. And I applied, and I was not hired. And I heard through the grapevine they didn't think I would be good with kids. I think it's because, again, I look so young, and would I have boundary issues with them. So I realized I didn't want to be unemployed the rest of my life, and I was really tired of being broke. And I was smart. So at that point I said, the one thing I think I can do is maybe I can get into medical school, and I will have a job the rest of my life. So that's why I applied to medical school. I'd been out for a couple of years. My mother died in that 2-year period. My father wasn't doing so well, and I was on my own. So I applied, and because I had no money, I looked to see what were the cheapest medical schools in the country. And it turns out that if you're a Texas resident, your Texas public schools are your best bet. So I applied to the Texas public medical schools, and I did get in on the first go-round, thank God. And I went to University of Texas Medical Branch at Galveston. And because of some experiences I had in college around reading Jung, I don't know if any of you know about Carl Jung, I found that way of thinking and analyzing very interesting. And because of my experience at the children's unit at Austin State Hospital, I thought maybe psychiatry is really where I belong. I had a degree in biology, but I didn't see myself as a researcher. I had done some research, and it wasn't all that interesting to me. So to become a psychiatrist, you have to do a number of things. First of all, you got to understand it's not the same as a psychologist. That's a whole different path. They go a different direction. They get a PhD after college. But to be a psychiatrist, I'm a physician. I have an MD. I can prescribe meds. And the training path is, you do your college, whatever that is, 4 or 5 years. Sometimes people take a little longer. And by the way, there were people in my medical school class that were in their 40s and 50s. I mean, there were people who decided very late in life to do that and went for it. And they were usually very interesting classes. They took things very seriously and were very good students. So I was a little bit older than average when I entered. So to become a psychiatrist, you do your 4 years or whatever of college, and then medical schools, 3 or 4 years. There's different programs around. There used to be rocket doc programs where you could get done in a year earlier. And then you do a residency, like a postdoc. So you get an MD, which is equivalent to a doctoral degree, and then you go off for specialty training. And in psychiatry, the specialty training is, I got to think about this because they changed it, 4 years long. And I did a child fellowship, so I put in an extra year. So after college, I had another 9 years of training. And of course, all that time, I'm accumulating loans and debt. which as bad as it was then, I understand it's very, very difficult now for students to have to take out loans because it's hundreds of thousands, I guess, now. I'm going to say what it costs. Tuition at UTMB in 1977, where I entered, was $400 a semester. My God, you don't even have that at the collegiate level. If it hadn't have been that cheap, I would not have been able to go. So then I graduate, I go to my residency training. I chose to go on to California, to San Mateo County, which you've probably not heard of, but it's famous in my world. And it's famous because in 1963, President Kennedy started the community mental health movement, and it was the pilot project for community mental health for the whole country. The whole idea of public mental health in these, what they call catchment areas, where they treat all the people in that particular catchment area in the outpatient setting as much as possible. So I did my adult training in San Mateo, California. And while I was there, my father died. And I was homesick again. Here, what am I, 27, 28, something like that. I'm homesick. And I really wanted to be home. There really wasn't any family left in Austin, but I wanted to come home to Austin. So they have a training program in Austin. I thought, I'll call them up. I'll transfer. You know, I can maybe figure out a way to finish my training and come home. So I called the Austin State Hospital, where I had been a volunteer many, many years before, even though they wouldn't hire me. And I had actually come back as a medical student for a rotation. And I'd even come back, you know, at other times to visit. And I called them up and I say, so I'm a senior in my psychiatry residency. You got any unexpected slots? It's very unusual to transfer in the fourth year, very, very unusual. And they were like, no. But we have an opening in our child program. And I had never thought I wanted to be a child psychiatrist. And now that's how I became a child psychiatrist, so that I could come home to Austin, Texas. It was a 2-year program, and I transferred in my 4th year, so then that meant my whole postgraduate training was 5 years long. And then, what did I do then? Let's see, I'm looking at my list. Am I on track? Yeah, I'm sort of on track. And remember, you can interrupt at any time. So I come home, my family's gone. I did get married somewhere in there. And I went into private practice when I ended up. I lived in Bastrop County, so I opened a rural practice. I used a hospital in Austin, so I would go from where I lived to my office here and my hospital there. It was like this big triangle I would make every day, 100 miles or so. I did that. It worked out pretty good until I got pregnant, and then I got tired. Too tired. So I moved into Austin. And in the ensuing years, let's see, that's about 30 years ago. I've done just about everything you can do in psychiatry. You name it, I've tried it. I've been in private practice, rural and urban. I've been a medical director of hospitals. I've been medical director of children's units. I've been medical directors of residential treatment programs. I've worked with immigrants. I've worked with women's programs. I have a very short attention span. You name it, I tried it for a while. I was even a residency training director for a while. And in the mid-90s, I decided I wanted to homeschool my kids. I homeschooled my kids and worked. I homeschooled both of them through high school, and working part-time most of that. And then what did I do? The most interesting thing I did then was, and this will give you an idea of the breadth of things you can do in medicine and in psychiatry in general, I worked for the federal court, interestingly enough. I worked on a long-running class action lawsuit against the state of Texas around the quality of care in the Texas state hospital system. So I worked for plaintiff's side, and my job was to go from hospital to hospital and evaluate the quality of the care delivered in light of this lawsuit. And so I did that 5 or 6 or 7 years. The state then contracted with me to continue to do reviews for them, and then I took a job with the state as a medical director in the central office area. I've had a lot of different titles over the years. At one point I was in charge of all mental health in Texas. I was the behavioral health medical director for all the community mental health as well as the state hospitals. We've had a lot of reorganizations, and in all of that they split that job in two, and I decided I wanted to just work with state hospitals. So there you have my professional career. Any questions? Come on. It's much better as a conversation. It's much, much better as a conversation. Is it? Yes.
So you took a break to raise your family and raise your kids and things.
Mm-hmm.
How was it to get back?
Well, I always did a little something. So even while I was doing the raising my kids and homeschooling, that's when I was doing the work for the plaintiff side. So those were trips that I sort of would take punctuated. And that work, like a lot of work that you do, and you think, oh, this is sort of over here, that opened other kinds of doors, because then I got a reputation as a quality improvement expert, apart from being a physician, and then I got actually, because it was a court case, I got known as a partial forensic psychiatrist. I mean, just by taking a job like that, and even though it really took me on maybe 10 to 12 trips a year, once a month I go for a week someplace, it wasn't direct care, but I kept my hand in that way. I went right back into clinical practice in the late 90s. I just took a couple of contract jobs where I worked at the local mental health clinic as a child psychiatrist. It wasn't really that hard for me because I'd sort of kept my hand in, although I wasn't seeing patients, I was reading records. And so to read records and evaluate the care, you still have to know the meds, you still have to know, are they evaluating properly, is the documentation reflect the standard of care. So that worked for me. Some other specialties might be very hard to do that in, like a surgical specialty. I think you would have a hard time to jump out and jump back in. But lots of women do this. Work part-time is probably how it mostly occurs. I have a physician right now who's the medical director of Waco Center for Youth, and she's full-time, and she called me on the phone. She said, I'd really rather work part-time because I have kids, and I'm working very hard to accommodate that. As a woman, I really understand that. A lot of people help me along the way to have an unusual schedule and come back. So you can do that. And I know that some of the other specialties, you can do that a little easier and work part-time. It's very hard to be a part-time surgeon. I'll just lay that out there. But the more cognitive specialties like pediatrics or internal medicine, you can probably work part-time. It's hard to be completely gone. It's very hard for people to jump back in after being completely gone. You have to be proctored and supervised, and in some cases you'd have to actually go back and pay for retraining, which could be very expensive. But so I think most people try some way to keep their hand in it if they're going to take time off. That's a very good question. I think lifestyle issues, as more and more women go into medicine, have come more to the forefront, and some of these alternate ways of practicing are more common now, so it's easier to do them. The expectation is not that you kill yourself with an 80-hour-a-week schedule like it used to be when it was all those men who had women at home taking care of them. It's better. It's definitely better. Any other questions? Yes?
What was the residency like for psychiatry? Because I know that oftentimes here, even within like pediatrics, they are on call for hospitals, and they also are in the clinic. But what is it like?
Well, remember, anything I tell you is 40 years old. Although I helped run a residency, I guess it was the late 80s, mid 90s. It can be very variable. Different programs are run differently. I specifically chose the program that I went to, not only because it had that wonderful reputation, but because, well, you don't go into psychiatry unless you have a reason. Everybody hears about psychiatrists are crazy. People do sort themselves out into specialties according to their personality. I mean, that's absolutely true. And I think most people that go into psychiatry have a reason related to they either experienced it in a family member with mental illness, or there was something in their background that drew them to it because they had contact with that. Now I've forgotten the question I'm answering. Remind me again, because then I'll get there again. Oh, so for me, I have a predilection to depression, and I've had major depression. Not currently in treatment. I feel fine. And I also come from a family where there's a big propensity for panic disorder. So I get anxious really, really easily. And I saw that in medical school, when I was sleep deprived, because even as a medical student, you'd have to do calls and kind of go in. I noticed that if I'm sleep deprived, I start getting paranoid. I mean, I just put it out there. I don't do well. And so I looked very hard for a residency program that would not require me to be on call for long stretches, like every third night for a year. I knew that me personally, I would not be able to tolerate that. And so I asked around and I read about a lot of the programs, and I found a program that didn't require call except for 6 months in the first year. That's unusual. I don't even know if that exists anywhere anymore, but I specifically chose it because it was small. I would have direct contact with the attending physicians, nurse. I wouldn't have me as the intern and then a resident above me and then another resident and then the attending. I wanted to learn directly from people who knew the most. And this was such a small program that there would never be another resident around where I was practicing. It would be me and the attending. And the attendings were Stanford professors. So I didn't have to try to get into Stanford's residency, which would have been very hard. I got into this residency up the road where the faculty was clinical faculty at Stanford, and so they were really bright, really smart, and I got personal attention, which was important to me because I wanted to learn in a more relaxed environment, because I just know I don't do well with certain kinds of stress. So you can do that, and I'm testament to the fact that you can take time off, you can flunk things, you can be imperfect. The most important thing is to assess your weaknesses and figure out a plan to manage them. That's what I would tell you, and that would go for anything you went into. Don't ever shut a door to something you want because you think you don't fit it. Your job is just to figure out how to make it fit, and you can get creative. This day and age, when we have the internet and you can research things, you can find a niche somewhere. I'm convinced that it's possible to do that, and I was able to do that, long ago when it was harder to get information on different things. So I chose that residency because I thought that, one, it would be good for my mental health, and I would get excellent training, and both things were really, really true. I remember those guys saying that I was as good as any of their Stanford residents, and it was because I had the time and a little bit of distance so I could think, because I need that. It's probably one of the reasons why I chose psychiatry. I'm an introvert. I don't really want to be in a room in front of a bunch of for me, it's just really difficult to be on all the time, and I wanted something I could do by myself. And back then, at least, as a psychiatrist, you could have an office by yourself. You didn't even have to have a reception if you didn't want it to, if you're willing to do all that part yourself. I think it's harder now. But I wanted to run my own show, and I wanted to do it my way, and I wanted to be able to do it by myself. So psychiatry was really good, and there was a lot of mental illness in my family, so I already had to learn skills to manage that, and I was curious. I think for me, it is the most intellectually stimulating specialty in medicine. And why would that be? Well, it's because if you do it right, you have to learn all the biology, and then you have to learn all the stuff about the brain, which nobody really completely knows, and it's such a wonderful area of research. And then you're excused to learn all the psychology, and you can broaden it out to sociology. So basically, if you're a curious kind of person like I am, it's an excuse to be able to poke your nose anywhere you want and say, oh, it's part of my job, which I find really helpful. And when I became a child psychiatrist, it even broadened out to, hey, I can go to the store and buy toys for my office. I mean, literally anything that I was interested in, I could find a way to plug it into being a psychiatrist. Because psychiatry is all about people and their stories. And those stories can go anywhere. A good psychiatrist is busy listening, because that's the only way. We don't have any good tests. I can't tell if you're schizophrenic by doing a test. I have to talk to you. I can't tell anything about diagnosing you unless I know your story. And so you have to be curious about other people's stories. That's definitely true. And for me, the thought of doing something else was like putting myself in a box and be closed in, whereas when I thought about doing psychiatry, it was like, oh, I have license to think about anything that I'm curious about, because somehow I can find a way to make it relate. That was a long answer. Did I answer the question? I wander around. Sometimes I get there, sometimes I don't. The actual training program was, it's 4 years. Usually in the first year, half is inpatient work and half is regular medicine, because what people don't really understand many times is psychiatry is a branch of internal medicine. So in your first year as an intern, you do half psychiatry and half internal medicine, regular internal medicine, like treating people with diabetes and people that come into the ER and things like that. And then the second year is usually spent doing lots of different rotations in different places. Like you might go, for me, I think I went to an intermediate care facility and did that flavor of inpatient work, and then a geriatric care center and did that flavor of work. And then I picked up my own patient load in the second year, which I carried through the end of the third year. I would have had them for, through the fourth year if I'd have stayed. So I had my own psychotherapy patients that I saw that I prescribed medicines for, and I would do intakes and with new patients. And I would move from clinic to clinic too, so I could experience different patient populations in the area where my training program was. So programs are different. If they're all different. They have certain standards to meet. They'll all have some inpatient psychiatry. They'll all have some outpatient psychiatry, some what's called consultation liaison, where you go and help the internal medicine doctors take care of the psychiatric aspects of maybe an inpatient who has depression with their diabetes or something. That's called consultation liaison. A rotation in child and adolescent. You get a smorgasbord, basically. They sort of introduce you to all the subspecialties through various rotations. And then you carry a patient load of your own. That's kind of an outpatient long-term cases. I trained long enough ago that we were still doing Freudian-based psychoanalytic psychotherapy. I don't think they do that so much anymore. Everything is like cognitive therapy, and it's like 10 sessions, you should be done, that kind of thing. But, we did the other style. One of the unfortunate things that's happened in psychiatry is because we cost a lot. If you those 9 years cost a lot, and so to go see a psychiatrist is costly. And if we are an employed physician someplace, we're an expensive employed physician. So they don't really pay us to do psychotherapy anymore, which is really sad because that's the thing I like best about it. Prescribing meds is kind of boring. I like diagnostics. I love the puzzle of a new person presenting and me trying to figure out, well, what's going on and how can I help them. So if I were in practice, I'd still get to do that. But it's very difficult for psychiatrists, unless they're in private practice and really work at it, to find a way to be able to do psychotherapy anymore. It's just much cheaper and easier to go to a social worker who can do psychotherapy, or a licensed professional counselor who can do psychotherapy, a psychologist, although their rates are creeping up toward ours. So one of the things I most liked about it is hard to do now. That's one of the things that's changed over the years. Any other questions? Yes?
Could you describe a little bit about what the 10 hospitals are?
Sure. The public mental health system in Texas. The public mental health system has two pieces. It has the inpatient piece and it has the outpatient piece. The inpatient piece is directly run by the state. I am an employee of the state of Texas, and all of my hospitals all the employees in those hospitals pretty much are employees of the state of Texas. And we have 10 facilities, 9 of which are hospitals, 1 of which is an residential treatment center for adolescents in Waco. And then the other 9 are spread all over the state. Let's see if I can remember them. Austin State Hospital, it's where you would expect. San Antonio State Hospital, it's where you would expect. I'm going in alphabetical order. El Paso, that's the only way I can remember them. Kerrville State Hospital. North Texas State Hospital, which is a very interesting place because it's in 2 cities an hour apart, Wichita Falls and Vernon. Anybody ever been to Vernon? You know about Vernon, Texas? Yes, I remember the first time I went to Vernon, Texas in 1991 as under that lawsuit to look at their quality of care. And when I checked into my hotel and they handed me a fly swatter, I went, oh my God, I have reached rock bottom. And I think they have more hotel space there now and more restaurants. I was a vegetarian, so there is no place to eat. I'm just going to have to fast until I leave Vernon, Texas. I started staying in Wichita Falls and commuting after that. So then we have, after North Texas, we have Rio Grande State Center, which is also really unusual. It's in Harlingen, Texas, and we just changed it, but it was, it had a state hospital section, a state-supported living center section as part of it, and an outpatient clinic. It's very unusual. And we just recently spun off the state-supported living center side to that division in HHSC. We were always running it, but there really was another division that does that, but now it's split apart. And then we have Rusk State Hospital in the large metropolis of Rusk. Terrell State Hospital in Terrell, Texas. We have such creative names, don't we? And then Waco Center for Youth in Waco. I think that was all 10, yeah. I went in alphabetical order. So that's the inpatient side. And we used to, years ago, when I rotated at Austin State Hospital, it had 800 patients. In the old days, it had 3,000 patients. In the 60s, the mental health movement was all about moving people out of these institutions and into the community, and that was the community mental health movement. And so things keep changing. It's changed a lot since I was there as a resident. We now have, I think, 250, 60 patients there. And I think we may be closing some more beds. The goal is to get people into the community for their treatment and not in a hospital for treatment. And we also have, for example, Austin State Hospital would pull patients from a 39-county area of Texas. When somebody needed, they'd go, well, it'd be better to be treated in your city of origin. If you had to be in the hospital, it'd be better for you to be in, like if you were from Houston, to be in a Houston hospital, not have to go all the way up to Austin. So we now have contracted community beds that are closer to where people live. And so as those sorts of things happen, the state hospital system has shrunk a little more. So in the old days, we admitted people who would walk up and go, I'm suicidal, I want to be in the hospital. Those are called voluntary admissions. We do virtually none of that anymore. We don't have space for those kinds of patients anymore. We treat people who are committed. Those are called civil commitments. To be committed to a state hospital, you have to be a danger to yourself, a danger to others, or unable to care for yourself on the basis of a mental illness. That last part's really important. And people can be picked up on the streets. You know, like if you see somebody who thinks in dire straits, you can call the police, and they go and they sort of do whatever they do, and they bring them to us, and that's called an emergency detention. We have, I think, 48 hours to make up our minds, and then we would have to do a commitment ourselves. I mean, a physician writes out a certificate and goes to court and has to testify. So that's a lot of the state hospital doctors' work is to testify, and the courtrooms are actually in the state hospitals. The judges come to us to make it easier in many of our locations, not all of them, but many of them. And a person can be committed for 14 days. That's called an order of protective custody. They can be committed for 90 days. That's called a temporary commitment, or they can be committed on an extended, which is a year long. All of these things can be renewed. But you can only stay if you're a danger to self or a danger to others or unable to care for yourself on the basis, immediate deterioration on the basis of a mental illness. So our facilities are locked. There's another whole category of ways you can get into us, which are called forensic commitments. If you're picked up on the street, usually one of the most common things is trespassing, and you're charged with trespassing as a crime. And it's determined when you go to jail that you're mentally ill. That's probably the real reason why you're there. And you don't clear in a couple of days, meaning you're not able to participate with your attorney in your defense. You're declared, and it's again another judicial proceeding. You're declared incompetent to stand trial, and you're committed to a state hospital for us to restore competency. And that's basically you have to prove up by the end of that treatment that you understand the nature of the charges against you, that you understand the ramifications of being convicted of that crime, and you're able to cooperate in a reasonable fashion with your attorney. And once we get you to that point, we send you back to jail, and then you work with your attorney and you go through the rest of the judicial process. And then there's a second kind of more notorious type of forensic commitment called not guilty by reason of insanity. You've probably heard of the tragic cases of a mother who kills her kids and she's psychotic, and those people come to us too. It's very sad because many times we clear them up pretty quickly that they were psychotic for whatever reason, which means an inability to distinguish reality from fantasy or other things going on in your head. There are many times people who've never been on meds, we put them on meds and they clear immediately, and yet they're with us for years. Because depending on the heinousness of their crime, we would love to release them and we send them back to the courts, but the community, because of the heinousness of the crime, does not want them back. And so they could be just like you or me, and yet they're stuck with us and they're locked up for years and years and years. It's very, very sad. We work very hard to convince judges to let those people out. I can tell you, how are we doing on time, by the way? I got 10 minutes? Okay. Well, so this will give you a flavor. We had such a case long years ago in one of our facilities, and this person really, and I have to be very careful about how I talk about it because people have privacy. They were ready to go. They've been ready to go for years, and so we were working hard to get them back to their community of origin and release them after their heinous crime, because their crime was like 20 years in the past or something like that. And I worked with the facility back then to get a treatment plan in place that would make the judge feel comfortable. Like, if we release them, they will have this person in charge of them. They'll have to go check in with this therapist once a week. They will go to this treatment group, and they'll live here. You know, we had it all laid out. And still, we convinced the judge, we convinced the family, the patient was ready to go, but the community mental health center, that then it becomes their responsibility to monitor the patient. They get assigned to an outpatient center where they live, didn't want to take the patient. And they were like, they were refusing to accept them. And so the judge was very reluctant to release unless the community mental health center accepted the patient. And so I had to go. I went to this very big proceeding where I testified against the director of the community mental health center. And he got placed in contempt of court and put in jail. And we released our patient. I'm still friends with that particular director. So we do all kinds of interesting things in our line of work. But that's the breadth of types of commitments we see. Patients generally have schizophrenia, bipolar disorder, major depression, or suicidal on the basis of some other illness, some of which are sort of hard to name. We don't treat so much things like just plain anxieties, or we don't see much panic disorder per se in the state hospital system, because those things are, although they make people miserable, they don't make them unable to care for themselves or a danger to themselves or others. So that's what we see in the state hospital system, and it's very medication-based treatment, because we do conceptualize that those disorders are biological brain disorders. Now, it doesn't mean they don't have all kinds of other things around them. You know, there's lots of things that is helpful that's not related to meds, but meds seems to be the fastest ticket out of being in a hospital for those particular disorders. In the community side, those are not all the community mental health centers in Texas, and there are 39 of them. They all have various different names and various catchment areas of how many counties they cover. They are quasi-governmental entities that are contracted with the state to provide outpatient mental health services to the, see if I get this right, priority population. Again, schizophrenia, bipolar disorder, and depression. The state doesn't pay for all types of mental health care. You have to have one of the big three and meet some criteria about the severity of your illness. You can still go, but they might charge you. You know, you might have to pay. Some of them do what I call other books of business. Their county might kick in funds, and so they treat another range of patients and things. And they take Medicaid, and some of them will take private insurance. So, did that answer your question? Okay. Yes?
So, I plan on going to pharmacy school next year.
Uh-huh.
And what has been your relationship with clinical pharmacists?
Oh, I have a wonderful clinical relationship with Dean Lynn Krisman at the School of Pharmacology in Austin, and we also have connections to the School of Pharmacology in UT San Antonio. We use clinical pharmacology in our hospitals. There are pharmacists or pharmacologists that specialize in psychopharmacology. That's quite the subspecialty. There's excellent training for that in both UT Austin and in San Antonio. We get residents from those programs, and they do work for us. I mean, for example, I'm a member of something called the Executive Formulary Committee, and those are the students who do the drug monographs for us. And if we want to add a new drug to our formulary, basically a literature search has to be done before we can add it to our formulary. It could be FDA approved and on the market, but we go through a formal process. We don't just automatically add anything. And so those students, under the tutelage of either the school here, school in San Antonio, or the school in Austin, will do the literature review and prepare a formal paper, and it's presented at the Executive Formulary Committee, and then the members vote to whether we're adding it to our formulary at all. So we use the students that way. We have clinical pharmacologists on staff at several of our hospitals. They see patients. They go to treatment team meetings where the psychiatrist is there, the nurse is there, the social worker is there, the pharmacologist might be there, and they together formulate aspects of the care plan, and they help with the finer points of the meds that are used. So it's a big thing in my field. And Lynn Krisman, he's known all over the country, for his psychopharmacology work. And I interface with him on a monthly basis. He's on a member of another committee I currently run. It's called the It's a work group to reformulate the Texas parameters for the use of psychoactive meds in foster kids in Texas, which has been a big political issue, and I'm broadening it just to all kids. But we develop guidelines that then can be adopted by the Medicaid program. They're adopted in the state hospital system. They're adopted in the community mental health centers. Here are the guidelines. So if I'm going to go out and do quality care reviews, I'm going to look at the parameters and see if they've met them. And that's how we keep up with, because one of my responsibilities is the quality of care in the system. So yes, it's a big part. It's a wonderful field. That was a great question. Any others? Oh, and there are bazillion other professions related to mental health. We have APRNs that are psychiatric APRNs that function like physicians in our system. They do have oversight from physicians, but they do almost everything that the physicians do. They are not yet allowed to testify in court the way our physicians do, but we use APRNs. If we could get them, we'd use psychiatric PAs. Of course, they're hospitals, so we also have internal medicine doctors, family practitioners, and regular PAs and APRNs who do internal medicine type stuff. We have social workers, clinical social workers who work on admission stuff and discharge planning and run psychotherapy groups. We have nurses that are psychiatric nurses, which we have huge shortages. You want to become a nurse? We have huge needs. We have openings in all of these. We always have physician openings because psychiatry is, if not the biggest shortage specialty in the country, it's second. And child psychiatry, I'm a child psychiatrist, in the whole country, the last time I checked, there are only like 7,000 child psychiatrists for a population of getting close to 400 million. So for job security, I picked the right thing. I can always find a job. And that's been good because I've actually been let go from 2 jobs in my life. I also want to point out to you that you have to, as you go through life, master failure. Failure can be your best friend. As I've tried to point out to you, I have many failures in my lifetime, and some of them have been that where I was working, they didn't like me and they let me go. I think it was for the right reason and that I was trying to do the right thing and they didn't want me to do that. And here I'm running, the entire hospital system for Texas. So don't let anything stand in your way if you really want something. There are pathways, and there are honorable ways to fail, and I encourage you to learn the honorable ways to fail, and to learn as much as you can from that, and then pick up and go on, because that's where you learn enough to actually be good at physician work, because you're dealing with people at their most vulnerable. People will tell things to their physicians they will not tell to anybody else, and especially in psychiatry. You will hear people's innermost stories, and if somebody's going to be that vulnerable to you, you have to have the strength of character in yourself to have compassion for that and not judge that. So that's the good thing about my line of work, is it has opened me up. I have lived vicariously just about anything you can think of without having to live through it myself, and I was able to learn from it. It's a highly recommended profession in that sense. Anything else? Yes?
How do you feel child psychiatry is different from general?
Oh, well, we're better. We're just so much better. It's not even close. I'm saying, if you're an adult and you want to go get some good psychotherapy, find a child psychiatrist who's been well trained to deliver. Because we learn more about child development. We actually learn a whole lot more about human development than the general psychiatrists do. And again, people sort themselves out to the specialties they're kind of drawn to. And I think that the kind of person that is attracted to child psychiatry is just a warmer human being. Sorry, I didn't say that, did I? Well, it's like pediatricians. Everybody knows pediatricians are usually very warm because they're kid-oriented. They can relate to children and they have that kind of warmth to them. Surgeons are the sort of people who can distance themselves from the problem because they're dealing with blood and guts, and they like it to be done now and they want it to be over with, You sort yourself out in a specialty in medicine according to, your personality and what you're good at and what you're not good at. And it's, as I said before, the most important thing is to figure out what you're good at and then immediately figure out what you're not good at. That does not have to stand in your way, but you have to have a plan to manage it. Like I had a plan to manage. I get paranoid if I'm sleep deprived. I get really anxious. I do really well if things are calm. So how can I arrange a calm environment so that I can get the best out of me for my patients? And so that's what I did. And you can do it too, once you figure that out about yourself. That's what you're supposed to be doing at this age, is figuring that out. It's not obstacles, it's just It's like you're dealt that hand of cards. You can either make this with it or that with it. You just take what you're given and you figure out a way to creatively do something really good with it. And you can. Alrighty, are we done? Yes?
Are there any opportunities with the state health system for internship or shadowing college students?
Potentially, I get that question every now and then. The issue always arises if you, say, go into one of our facilities. Nobody can go into our facilities without certain things, which, you have to have had all your shots for, it sounds weird, but yeah, it's a healthcare facility, and if you're actually going to be in there, and there's certain trainings you have to do, that is what has gotten in the way of having people just come in for very short periods of time, because like the stuff you have to do can take 2 weeks solid, 80 hours to get through all that. We've been working on ways to shorten that so we can bring in volunteers more easily, students who only can come for short periods of time. If you're only wandering around watching somebody, that's a little easier than if you actually are going to do something. Even our residents, they have to jump through lots of hoops. They have to have malpractice insurance, and they have to prove up this, and they have to have background checks. You all have to have background checks. You can't set foot in a facility and do anything without a background check. The list is long. It's not. It can be overcome, and we do overcome it. The facilities work very hard to overcome it if they have a program that wants to work with them. So there are ways, yeah, we can do all that. There are people that follow me around sometimes. I'm like, yeah. They come in, they want to learn. You want to learn about it, all the paper shuffling I do? Okay, yeah, all right. But I'm actually in a policy-making position. I help write TAC code, Texas Administrative Code, which is the level of law that interprets statute. The legislature goes and makes changes in the statute, and that usually runs downhill to now you got to have regs that put the statute, implement the statute, and I help write stuff like that. I help enforce stuff like that. I go to lots of policy making things. So people do follow me around to see what that kind of the job is like, and so at central office we can do that too. The facilities do. Now if you want to go to a community mental health center and look at the outpatient end of the world, that's a different story because that's not run by us. You would have to contact their administration, and they might have a program for that, or they might be willing to develop a program like that. We don't have any rules that say you can do that. Of course they can. It's just the hoops that have to be jumped through. Everybody's got to be background checked. They have many of the same stuff. They have to meet the same standards in certain areas as the hospitals do. But if you're persistent, you can probably make it happen. You need to think of it long before you need it, though. You're like, plan now for 2 years, a year from now.
I was going to say, we do have some experience getting psychology students into the Blue Bonnet Trails.
Yeah. Oh, Blue Bonnet. I was a contractor for them briefly. Saw patients in Luling. It's doable if you're interested. Back when I was a volunteer 40 years ago, it was a lot easier. It was a lot easier back then. But there are ways to do all of that, and almost all of the hospitals have volunteer centers. They have a formal intake and a process for volunteers. Years ago, one of the things that really makes me sad is years and years ago, a lot of the what we call them PNAs now, which means psychiatric nurse assistants. They're the direct care staff, or we call them child care workers. I forget what are they? They're the people who are there daily taking care of people. And we used to get lots of college students years and years and years ago. And it was great because people were interested in this kind of work. They'd come work at a state hospital or something, and then they'd come back, 4 years later as a social worker. But they changed the jobs in such a way it made it really difficult for college students to take those jobs because they were no longer part-time. And I've been advocating that we get back part-time jobs and variable shift jobs and PRN jobs so that if a college student wanted to taste of it, they could come in and actually work and earn some money and get a real taste of it and still go to school or do it as a summer thing. And your husband's been good about getting some of that going again because I miss those young people. They added interest. They were really usually good with patients, and they were just curious. And because they're very low-paying jobs, unfortunately, when we don't have access to young people who are interested in it, we get people who maybe couldn't get other kinds of jobs. And it's, I sometimes say they're as traumatized as the patients we have. They're middle-aged and they can't get more than a $10 to $12 an hour job. So you see one of the problems. Now, we do have wonderful, dedicated people who've been with us for many years. But they're very special. You have somebody who's good at it and has stayed 30 years because there's there's not a whole lot of ways to move up in the system from those job titles. You have to go back and get training. But we have some. So I'm hoping that we can get more young people working in all of our systems. Yes?
This is a follow-up to my other one.
Mm-hmm.
So I plan on going to UT
Mm-hmm.
next year. What does your residency programs look like for psychiatric pharmacology?
You know, I'd have to ask Dr. Krisman about that. I don't really know how they're structured or arranged. He runs them. He's a good friend of mine. I've known him for 20 years, but I'm sure it's on his website. I'm sure it is, that they describe the whole program and how you get through it. They have, I know, you can become a registered pharmacist, I guess, but a PhD pharmacologist is a different thing, and then there are those that are clinical pharmacologists who actually see patients. The only thing a clinical pharmacologist can't do is they can prescribe and they can assess around the medications. They cannot diagnose, however. So they have to depend on a physician to do the diagnosis. I don't know if that helps you any at all. I don't know how long those programs are, actually. I would guess in the nature of 4 years, because it's quite a lot of stuff to learn. That's the School of Pharmacology at UT.
Yeah. What was the contact you said?
Oh, Lynn Krisman. He's the dean. Yeah. Exactly. Nina sent you. He knows who I am, yeah. I saw him just last week. He's really good. But they've got good people at UT San Antonio also. They have a good school. And they have we have a contractor from there that goes to San Antonio State Hospital. So we still have connections formally to that. But we used to have a lot more than we have now. The 2003 legislature, there was a big budget crunch, and they cut a lot of our linkages and programs and things. And here it is, 14 years later, we're building them back up again. Like it's new and never been done. That's what I love it. There's no institutional memory. It's like, we used to do this. This is not new. You stick around long enough, you see everything cycle. Yeah. Anything else? Well, let's see if I had anything on my list that I didn't cover. What I don't like about being a psychiatrist, that was on my list. Are you curious? The stigma. Mental patients are stigmatized in general. But those of us who treat them are stigmatized too. When was the last time you saw a positive representation of a psychiatrist in a movie? Like, never. We're crazy. Well, we are a little bit, but yeah, that's hard. We're discriminated against by insurance companies. We have lots more hoops to jump through to get paid than your average physician. So insurance companies don't like us. Our patients frequently don't like us. You basically have to be a very persistent person, because you think about the kinds of persons that get committed to hospitals. They don't want to be there. They're locked in. They don't want to be there. And so you're the psychiatrist. You're the authority figure they see as the one who locked them in. So especially at the beginning of treatment, we're frequently demonized by our patients. So the government doesn't like us. Insurance companies don't like us. The public doesn't like us. Even our patients don't like us. And when I went to medical school, and I declared that I was going to go into psychiatry, I got condolences. And even my father, who was still alive at that point, he went, what? So you have to be persistent to become a psychiatrist, because there's not a lot of positive goodies coming back, except from other psychiatrists or people of that sort. The rest of medicine, we are stigmatized by the rest of medicine. So that's the thing I most dislike about it, is that there's a lot of perceptions that you constantly run into that are negative, that you just have to withstand. You have to really want to do the work. And then you get occasional time, like I had a patient that I treated when I first came out, many, many, many years ago. I treated her in my rural practice in Bastrop. This person called on my home phone, and my husband, when I got him, said, somebody called you. And I said, well, who was it? And he said, well, I don't know. And he gave me the name, and the name rang a vague bell, and I didn't know who it was. This is a scary thing to do. I called the number, and it was somebody I had treated my first year out, and she remembered me, and she said I'd changed her life. I'm going to cry, because you don't get that very much in psychiatry. And she wanted me to give her a referral for her son. And she had divorced her husband that she was with when I treated her, and blah, blah. Anyway, she said I had changed her life for the better. You don't get that very often.
All right.
Yeah.
Well, let's thank Dr. Muse again.
Yeah. You're welcome.
For more information, please visit tlu.edu.